next presenter is going to provide a description of practical application of aviation medical aspects in the ICAO context and its effects on safety, public health, and the economy of various sectors. So if you would join me in welcoming Dr. Ansa Jordaan.
Good afternoon, everybody. Thank you for attending this on a Friday afternoon, and I hope it's worth your while. So, aviation medicine. I'm sure you guys is not going to know everything I'm going to tell you this afternoon. Please, at the end, ask lots of questions. So, let's start you off. Okay, what is aviation medicine? Basic question. How does it work in ICAO? And then our stakeholders, and then, of course, the regulatory aspects which we need to look at. Aviation medicine, it's a little sentence, but it's got a lot of information. We're looking at preventive health, we're looking at occupational health, environmental health, and clinical medicine, which is normally what a few different medical disciplines would do. But then we specifically look at the psychological and the physiological adaptation in aviation. And this is where it becomes a bit different. If you're 8,000 feet above the air and if you're on the ground, your body systems doesn't work the same. Okay, where we fit in ICAO, Air Navigation Bureau, and aviation medicine is part of safety. Important, and you'll see why. Our strategy, we collaborate with all our stakeholders, and we need to collaborate with all our stakeholders because we are a very small section within ICAO doing a lot of work that you will see just now. Our way is to try to get to the lowest level that I put down there, and that is to empower the people we work with. It's good to involve people, engage them, consult with them, but we really want the buy-in of the people that we're working with, because only then you can make a change that you want to do. And then, because we are an international organization, we need to work at a global perspective, and only later we can take it to a more regional and then even lower down to a national perspective. Now, that is very difficult to harmonize global aviation medical standards. If you look at color vision, it's one example. If you fly in Australia, you might fly with a color vision defect as a transport pilot, whereas in other countries you might not even have a private pilot license. So we need to try to harmonize those regulations. Our big partner, WHO, and it's very important to understand that although we do aviation medicine, we do the application of medicine in the aviation environment. If we look at specific medical requirements, we have to look at what WHO is saying, because they are the lead in all the medical requirements. So when we look about Zika and we talk about disinsection, we need to listen to what WHO is saying. We can take what they're saying and apply that to the aviation environment, and we can advise them and say what we think they should be doing. But at the end of the day, any medical-related decision is still the domain of WHO. These are all our partners. Left side, the CAPSCO, which I'll get back later, and then our clinical partners, which is more from the regulatory aspect. We recently also concluded an agreement with Pharma Flight, who will be doing some research for the aviation medical section on behalf of ICAO, which will be very interesting, which will be the effects of age and fatigue on flying. Okay, let's get to the regulatory medicine. ICAO has 19 annexes. The next 3 slides will show you where we are involved in these 19 annexes. Everything red is medical. So we're looking at the licensing of pilots. We're looking at the rules of the air, which, for example, would include what medical kits, what's the contents of the medical kits that's carried on board the aircraft. If we look at the operating rules of aircraft, of operators. So we need to look at fatigue, for one example. If we're looking at airworthiness, if you transport a patient from A to B and you need to use a ventilator or suction operations, or you need to fix a stretcher to the aircraft. As soon as you do any changes to the structure of the aircraft, it becomes an airworthiness problem, and then medical is involved. Facilitation is the one thing. It's not just passports. The other problem, or the other aspect of that, is the disinfection and the disinsection of aircraft. What products can they use? How do they do that? That's also all part of what we do. Second slide, Annex 11, air traffic services, especially when you do transport of sick passengers, or if you have a plane that might be quarantined because of a communicable disease on board. So we're involved in how you communicate from airplane to the ground, where you stop the aircraft, what do you do with the passengers? Where do they wait? Do you get public health to get on first? Do you take them off? Where do you put them while you evaluate them? So all of that is part of aviation medicine. Accident incident investigation, I don't need to say anything. I think Germanwings is very in the foremost of everybody's minds, and it generated quite a few bit of work for us. And then aerodromes, again in terms of these two aspects. One in terms of CAPSCA is we need to look at aerodromes preparedness to manage public health emergencies. Again, if I can use Zika as an example, do they have vector control measures in place so that they can kill mosquitoes and you don't get a mosquito getting on board an aircraft traveling from A to B and spreading the disease? The other thing is fire and emergency services, so we also have a say in that. And then the last slide on standards and recommended practices, dangerous goods. When you transport medical samples, if you transport blood, if you do transplants of organs, all of those need to be managed as dangerous goods, and there's specific ways to try to transport that. The latest way, that picture on your right, is drones that's now being used to transport medical samples, which it's good, but it's also a bit tricky. It's also, you need to know what they're doing and how they're transporting and what they are transporting and where. And people that say that, oh, now we don't have pilots in the cockpit anymore, we still need medical requirements for those operators on the ground that control these remote aircraft. So again, this is where we would be involved. And then safety management. I like to say that medical regulations is all about risk management and all about safety management. So in the end, everything boils back to safety management principles. Okay, our medical guidance material. I'm going to run quickly through these slides. So I don't, because I want to have some time that you can ask questions. We have the Manual of Civil Aviation Medicine, which is being reviewed at the moment. The next one we need to review is the use of problematic substances. That's alcohol and drug abuse, or use, which is going to be quite a big task. We have a manual, but it needs to be reviewed. It was last done in 1995. A lot has changed since then. Then we have all these other manuals. The important one at the bottom, CAPSCA manual, communicable disease manual, we have to develop that one. To give you an example of what's contained in the Civil Aviation Medicine Manual, all about licensing, physiology, how you examine a pilot or a cabin crew, how do you make a decision, is the person fit to fly or not? Aviation pathology deals with air accident victims, so we pretty much can say, was the people alive when they crashed? Was the cause of the accident a medically related cause? Was there a contributory factor that caused the accident that was due to a medical factor? So that's all in that part of it. Medical training, we'll get to that later. Communicable diseases, I've spoken about. Training, get to that again. I had an extra slide on that, so sorry. Fatigue, major thing that we need to look at. There is already a lot of guidance material for fatigue, but they are looking more at the scheduling aspects of that. We need to look at the medical aspects of fatigue. So we need to look at the effects that diseases have on causing fatigue. We know that pilots, people that are overweight, don't sleep properly. They get something that's called sleep apnea. And we need to see what are those effects on their fitness to fly. So there's a lot of medical aspects of fatigue that has not yet been really investigated and properly documented or mitigated. And then the public health emergency planning. I'll get to that now. Okay, I don't know how I'm doing for time, but this is what I wanted to show you. What are our real functions? So, fitness to fly. That is our main function, and there's a lot of factors that needs to be considered before you can say, this pilot is fit to climb into this aircraft and fly from point A to point B. So if we look at these factors, try to group them in certain areas, but you will see it's not easy to make a fitness to fly decision just based on a single factor or on a single medical condition, because there's always some other factors that's involved. A person might be fit to fly in a helicopter, but not in a fixed-wing aircraft, or the other way around. He might be restricted to height limitations because of a lung condition. It's so many factors that plays a role. So if you look at the physiology, that's the factors that we typically would consider. Age, of course, which we are, again, have to research. There's, again, questions, can we have a higher limitation for people to allow them to fly further at a more advanced age? And from our perspective, we would support that, because you don't want to lose the expertise, but you need to make sure that they are still sharp as they should be. Fatigue, obviously. Hypoxia, as you get higher in the air, you have less oxygen. That's unfortunately, that's how it works. So that's stuff that we need to consider. If you have a medical condition on top of flying high in an unpressurized aircraft, that has an effect on your fitness to fly. So any physical condition that might be okay on the ground and might be well controlled on the ground, and your specialists say, of course you can fly. Not necessarily if you want to be a pilot, because there's certain physiological factors that you need to consider. And I often had fights with specialists saying, but why can this person not fly? And then you have to sit down with them and discuss with them the environment, and then they understand. So it's not that easy. Mental, psychological problems, again, I don't want to really talk about German wings at this stage, but that's an example. And the bad part is, with mental problems, is there's a lot of pilots that do have mental issues. And there's some of them who doesn't tell us that they have mental issues because they're afraid that we would ground them. And there's some of them that take medicine for their depression, and they don't tell us because they don't want to be grounded. Now, this is a mental stigma which is much wider than the aviation environment, and that needs to be addressed, because I would rather fly with a pilot who's got depression, who's being treated for that, and is doing good on treatment, than flying with someone who didn't disclose that he has a mental problem. So these are the things that we are working towards after the German Wings, is to build a peer support program for pilots, but also a peer support program for the AME, because the aviation medical examiner also gets placed in a very difficult position in deciding whether someone is fit to fly or not. But you will still hear a lot of discussion on mental and psychological issues. Human performance, there's such a lot of factors that plays a role. Environment, as I mentioned earlier, our RPAS, or our pilots that does remote work, they still need a medical. And again, it will depend on type of operation, type of drone that they're flying, type of payload that it's carrying. There's a lot of factors that needs to be evaluated, and one of the major things for that would be vision and hearing, because communicating with your drone far away is going to be important. High altitude flying, you get lots of G-forces if you do aerobatic flying, types of flying that you do. So again, it's a different fitness level that some people might be restricted from doing because medically they're not fit enough to do that type of flying. Operational factors, fixed wing and helicopter flying. A person has a tendency to get epilepsy, might trigger the rotating blades of the helicopter might trigger an epileptic fit. So that's one of the main reasons why we do not want people with epilepsy to fly or who has a history of epilepsy to fly. Now, it has been, some of those restrictions has been made less strict as things have developed. So nowadays, in certain circumstances, people who has had epilepsy, who has been treated, might fly after 10 years, but there's a lot of requirements that they have to comply with. People with diabetes previously were not allowed to fly. Now we allow them to fly, depending on the type of medication they use, what the effects of the medication is he going to go over to insulin at a later stage? And if it does go over to insulin, then we need to track him and make sure that his heart is working okay and his vision is still good. So in the past, it was true. If you had a medical condition, you couldn't fly. Nowadays, it's not the case anymore. We can still fly if you have a medical condition, but we need to make sure that you are safe to fly, which means that you have to do a little bit more examinations, a little bit more blood tests, but at least we can keep you flying. And yeah, I can talk forever about this. Okay, preventive and occupational health. Preventive health is important. We recently, earlier this year, passed a new amendment where we expect states to give aviation-related health promotion material to pilots, cabin crew, anyone who has to have a license. So if you look at obesity, like that guy over there, on the one hand, it is a medical risk. So as soon as you are very morbidly obese, you have a risk of developing heart disease, stroke, diabetes, kidney disease. It's just sleep apnea with fatigue. It's just such a wide range of issues that you can have that can affect your ability to fly. So we're saying is, let's give these guys the information and let them rather prevent the disease than getting the disease and then end up not being able to fly. So obesity on its own is not just a medical condition. If you look at a safety aspect of obesity, if the pilot is in a cockpit and there's an emergency, they often have to go out of the window because that's the only way to get out of the aircraft. So they need to be able to fit through that aircraft. And it's bad. I was working at SAA, and we had pilots who couldn't fit through that escape hatch. And the same for cabin crew. Cabin crew are down on there's a separate area where they sleep, where their bunk is. And then if there's an emergency, they have to pull themselves physically up through an opening. So on the one hand, you need to be thin enough to fit through that opening, but you also need to have sufficient muscle strength to pull yourself up. And that is not easy. I'm not the ideal weight, but I'm definitely not very overweight. And I had difficulties getting up and getting out there. So you really, it's not just about the medical aspects, it's really about safety as well. If we work to CAPSCA, everybody asks, what is CAPSCA? And it's better to say it's CAPSCA. CAPSCA is about communicable disease because I cannot remember the acronym. It is Collaborative Arrangement for the Prevention and Management of Public Health Events in Civil Aviation. That's really a mouthful. So let's just talk about CAPSCA. So when we talk about CAPSCA, we talk about preventing the spread of disease, any communicable disease. We had Ebola. I'll show you this slide. I've actually got a very nice slide on that. Then we decided that communicable disease is not the only thing. We also need to look at other health emergencies that could have an effect on public health. So we're looking at radiation, Fukushima. We're looking at chemical events. We're looking at environmental disasters, volcanoes, tsunamis. All of those has effects on health, and not only the health of the people that is involved, but on the occupational health as well. So we now have a crew that needs to fly to that area, and they are afraid of radiation. So this is again where medical becomes involved and say, okay, you can fly there if we do this and this and this, or if we measure this and this and that. So it's really important for us to be on the ball on what's going on in public health. Initially, when CAPSCA started, we wanted to help states to implement the ICAO SARBs and the WHO international health regulations. Now, I said earlier that WHO is the lead agency for health, so they have what's called the international health regulations, which all state needs to comply with if you travel between one point of or one country to another country. So if you fly from here to US, you will have a port of entry, and that port of entry needs to comply with certain health requirements. So this is where the international health regulations comes in. But they manage airports, ships, ground crossings, all of those. So what we're doing is we are helping WHO to look at the aviation side of it, at the airports. And what we have done is in our standards and recommended practices, we have built in, or the international health regulations is included in those standards. And there's I think it's about 6 or 7 annexes that contain something about the international health regulations in CAPSCA. So we really need to be aware of that. We have sent, if there's any states here, we have sent a state letter recently on a CAPSCA survey. So please, if you go back, can you check whether you have completed that? Send it through if you haven't. And we've done the same for health promotion. If you could check that too as well, please. Like I said, initially we had communicable disease. Now we're looking not only at the flying people, we're looking at the end user, which is the public, the crew, which is the occupational exposure, and we need to sustain economy, because part of the convention of ICAO is saying we need to support development in aviation. So this is what happens when SARS happened in 2003. You can see there was a tremendous drop in hotels. There was a drop in transport. We had some pictures where it was completely empty. You get to the airports and the waiting rooms and it's empty. So we don't need that. We don't want that. This is a graph quickly on top of all the public health outbreaks we've had lately, looking at SARS, avian flu, swine flu, MERS, Ebola, Zika now, yellow fever in some areas. And what ICAO has done underneath is all the initiatives that ICAO has put into place to date to deal with these sort of outbreaks. Okay, this is basically giving you more information about CAPSCA. Publication of the guidance material. We have monthly calls with WHO, with CDC, with all our aviation stakeholders so that we can manage any public health emergencies. We have meetings. We have people that we train in states. So again, if there are state representatives here, we can come to your state, we can train your people how to prepare for managing a public health event in aviation. Go to this website. You will not be Disappointed. It's a very good website. Benefits of CAPSCA membership. Like I said, we assist you to implement all the regulations. We help you to build resources. We give you information, advice, guidance. The other thing that we do is we put together a team of experts, someone from ICAO, someone from WHO, someone from a region, and they'll come and visit the airport. They'll look at your public health emergency plans, and then we'll do recommendations. So we walk through, we see what you have, and so that we know if you have a patient that arrives with a communicable disease, you know how to deal with it. From when the patient is still in the aircraft, communicating to the ground, where you're going to park the aircraft, who's going to meet the aircraft, what are you going to do with the passengers. Zika, just a small example that Zika is not that much aviation related at the moment. Zika is mostly transported by the human vector, less than mosquitoes hitching a ride from point A to point B. But even so, the economical effects has been very good. Very good, very bad. I wanted to say tremendous. It's been very bad in the transport sector and in the hospitality sector. So what ICAO has done to date with Zika, Zika is a very hot topic at the moment in aviation circles because it's got a lot of cost implications for a lot of air carriers. So we are really looking at discussing and looking at that. So we participate in the meetings, United Nations. We have the World Health Organization's emergency committee meetings. We have implemented a forum. We submitted a proposal to the Multi-Partner Trust Fund so that we can do more in terms of CAPSCA, not only for Zika, but for other communicable diseases as well. With the Rio Olympics, we looked at flight information and we provided that to WHO so that they can prepare their campaigns and awareness and education surrounding Zika. So where do we have to concentrate our resources, that type of thing. What we have also recently done is we implemented the Airport Vector Control Registry, where anybody can have a view on whether an airport has completed the registry stating that we don't have mosquitoes there, or we have mosquitoes but we are managing them. And we've also made it wider, not to just include mosquitoes but some other diseases as well, because it's really only a matter of time before the next epidemic comes along. We're also at the moment we're developing a health risk assessment guidance tool specifically for aviation to help airports, airline operators to how to manage, if you get something like this, how to manage it, how to determine, do you need to disinfect your aircraft, or is the disinfection at the airport sufficient that you don't need to do extra spraying in the aircraft, that type of thing. Okay, the training, I'm a bit running behind, this you need to know. Aviation medical examiners is the training. We need to give them guidance on the type of examinations they need to do. How do you assess colour vision? How do you assess if someone has had a heart attack, whether he's fit to fly again? So that's a type of training that we would approve and look at. And then I mentioned the CAPSCA technical advisors. And then the last thing that we do, but not the least for all of you flying, is we ensure what the contents of medical kits should be. We look at the medical emergencies on board, so we would typically look at the data and at the results, and from that we could maybe amend the equipment that needs to be carried on board, which we have done recently, just needs to be published. Transport of medical specimens, we help with that. And then a very, very recent development that was happening an hour ago in one of our sessions was the air ambulance operations, where we have a requirement to develop standards and recommended practice for air ambulance regulations. So what we will be doing there is we'll look at all the safety related aspects. So how does medical equipment interfere with avionics, and what do you need to do? What do you need to train the medical people so that they can assist with the safety or that they don't jeopardize aviation safety? So there's a lot of the safety-related aspects that we will be developing new SOAPs coming soon.